Hi, everyone. Welcome to the PrecisCa GU Tumor Board. My name is Brian Reaney. I'm a GU medical oncologist at Vanderbilt, and I'm happy to be joined today by a prestigious panel of experts from around the country to discuss several cases. I'm going to go around and have everyone introduce themselves before we get started with our first case, and I will start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm a genitourinary radiologist in the abdominal imaging section at Washington University in St. Louis.
Thank you. Dr. Shaw?
I'm Chirag Shah. I'm a radiation oncologist at the Taussig Cancer Institute at the Cleveland Clinic.
Thank you. Dr. Abel?
Yes, thank you for having me. My name is Jason Abel. I'm a urologic oncologist, a surgeon at the University of Wisconsin.
And thank you. And Dr. Jakaki?
Hi, everybody. I'm Alexandra Drakaki. I'm a GU medical oncologist at UCLA. Happy to join you today.
Thank you all for being here. So we have several cases across the spectrum of GU cancer to discuss today. And we'll start off, and I'll sort of describe the case and the question, and then we'll go through some specifics of the case. And then I'll come back to all of you for an opinion, depending on what the specifics of the case are. So next case, 25-year-old man presents with hematuria found to have a renal mass and isolated enlarged lymph nodes. Patient undergoes surgery, has RCC with clear cell and papillary features and an involved node. And so the question is about next steps in management with further progression. So going back, the patient had, remember this is a 25-year-old man, so a very young man, episode of gross hematuria, presumably ECOG 0, we don't know performance status, but morbid obesity, hip replacement, and a TE fistula repair as an infant. And this is the imaging showing renal mass in the isolated node. And Dr. Siegel, if you could take us through what you see here.
Sure, we have a coronal and an axial view from a combined CT urogram protocol. And what that means is the patient gets injected with contrast material. They wait about 3 to 5 minutes to really get good opacification of the collecting system, renal pelvis and ureters. And then the patient gets re-injected with about an additional 75 cc's of contrast. They wait about 100 seconds to get optimal nephrographic phased imaging. So we have sort of optimal nephrographic phased imaging and pylographic phased imaging superimposed in one series. And that's good to just decrease radiation. With that, we see a mildly sort of hypo-enhancing mass in the left kidney upper pole that extends from the cortex all the way to maybe 1 millimeter from the collecting system. On the coronal view, adjacent to the aorta, extending sort of up and down, adjacent to the aorta, are multiple enlarged lymph nodes. And on the corresponding axial view, we can see one of the paraaortic nodes medial to the kidney and lateral to the aorta.
Am I imagining something, or is there something in the top of his right kidney, or maybe I'm hallucinating?
No, I do not see something in the top.
Okay. So young man presents with hematuria, has this smallish left upper pole mass in his kidney, but disturbingly some enlarged nodes.
Yeah, and it's that mass looks like it might be close to 3 or 4 centimeters in size, and as I said, it's almost touching the collecting system.
Right. And it doesn't, having seen a lot of RCC, it doesn't sort of characteristically enhance like an RCC, but could that be just because it's a CT urogram because of the timing of the contrast?
That's one option. In an ideal situation, we have pre and post contrast scans. Right. But as we know, there are some renal cell carcinomas that are more modest in enhancement, and the papillary RCCs are most commonly relatively hypo-enhancing.
Fair enough. So this, we know this patient underwent a nephrectomy with a lymph node dissection, clear cell with papillary features, ISUP nuclear grade 4, does have metastatic carcinoma. Dr. Abel, maybe talk about the role of lymphadenectomy in kidney cancer, both with and without these nodes. So if the scan had been clean for nodes and with this sort of small shoddy nodes, do you approach them differently, or what's the general, if you could summarize?
Yeah, no, I think that's it's a good question. the role of lymph node dissection overall in renal cell cancer is pretty controversial. We know that it probably does not benefit patients we have good evidence, patients with low stage disease, that it doesn't benefit them. And patients with metastatic disease, again, a really extensive lymphadenectomy doesn't really benefit those patients. I do think there's probably still a role for some patients, such as young patients with just really small nodes that you're probably going to remove extensively during surgery. If you look, the series that are out there, there's 2 or 3 series out there suggest maybe a 5-year treatment, a treatment-free survival of maybe 15 to 20%. So it's not a lot of patients that would benefit even in that circumstance. But maybe this is the patient that you really try to do it, as best you can. That being said, with a BMI of 68, technically it becomes a much more difficult situation as well.
Right. And I mean, I don't know what the highest BMI you've ever operated on, but is there a number above which you would just say, I can't operate on this patient, and then I'm going to ask Dr. Shaw if he would then radiate that patient, but I'll go to you first. Is there a...
I think, I think the answer is no. I think definitely we've operated on people in their 70s, with BMIs in their 70s or more. It really depends on the health of the patient. Some of these patients, even though they're exceptionally heavy, are still pretty healthy. And if they have something that's small and localized, I think it's reasonable. That being said, I do think if you don't have a lot of experience in heavier patients, or you're not at a big center that's used to, you need special equipment, a lot of times tables and stuff. So it is something that's daunting, I think.
And Dr. Shaw, have you ever radiated any primary renal tumors? When does that happen, if ever?
Yeah, so there's a growing literature both in the United States and outside the United States on using techniques like SBRT for small renal lesions. So there have been several studies published. We don't have level 1 evidence, but in patients who were otherwise deemed inoperable, that could be considered. That being said, those studies have not looked at patients who have renal lesions in conjunction with adenopathy. And so in a case like that, I would not see much of a role for radiation therapy, even if the patient's inoperable, because it's going to be difficult to be getting meaningful dose to the adenopathy as well as the kidney.
Right. And Dr. Drakaki, again, forget about the bottom bullet points. You're seeing this patient right after surgery. They're recovered. They've got this sort of clear cell / papillary grade 4 node positive. So the risk of recurrence is 50, 60, 70%, right? Are you going to give this patient adjuvant sunitinib?
Well, we have to have at least the conversation that all the adjuvant studies have been negative. The S-drug was the only positive one. We'll talk about toxicity related to sunitinib. I wouldn't be against it, but with this papillary, I always tend to prefer cabozantanib since it seems to be more effective in a papillary histology. I'll definitely send the patient for genetics. Being 25 years old is very concerning if there is an underlying syndrome that we're missing. Obviously, check a family history. So I will definitely have the conversation. Of course, there's some nivo-ipi trials around. Again, it's not the standard practice yet, but I will look where can we send the patient if there is an option in their area to offer more in the context of the trial.
Okay. Yeah, I agree. I mean, I think the guidelines are any patient with a renal mass less than 46, if I have the age right, needs genetic counseling, something like that. He's certainly well below that. So absolutely genetic counseling. I don't give a whole lot of adjuvant sunitinib. But I think I've given it twice in however many years it's been approved, but I've given it to young patients with node positive disease who came in and asked for it specifically. So it's not that many patients. As you say, there are IO trials ongoing. This would be a great candidate for a trial. And we know from a recent Merck press release that the pembro data was positive for relapse-free survival. We don't know any of the data. We don't know overall survival. But this adjuvant field is likely to be changing significantly, even in the next 12 months, and other trials will come out as well. So this talks about progression in the future. I guess I would probably just reframe the question, because that gets into a whole frontline discussion. I think I would just reframe the question about, as I asked all of you, how would we handle this patient now? And it sounds like surgery, if at all possible, as happened, maybe a discussion about adjuvant sunitinib. I think most of us would prefer to put the patient on an immune therapy trial. And then if pembrolizumab or other drugs are approved in this setting, then I think those drugs will sort of quickly become the standard of care.